Welcome back, guys. Now in this video, let's discuss about MCQs from the topic of labor. Guys, we have discussed all the concept which are needed for the labor. Right now we'll be discussing mainly the MCQs. Now, what is the most common presentation during labor? The most common presentation going to be cephalic presentation. See, what is the most common lie? The lie will be longitudinal lie. The baby will be in a longitudinal lie with head which is facing towards the pelvis. That is cephalic presentation. Head will be downward towards the pelvis. And what is the most common presenting part? The most common presenting part, okay, the part of the presentation which is lying over the internal cervical arch. See, the head is downside, but within this head or within this fetal skull, what is that part which is lying over the cervical arch? So that part of presentation which is lying over the internal cervical arch, that is known as a presenting part. What is that part most commonly lies over the internal cervical arch? That is vertex. Okay, the most common presenting part is vertex. The most common position of the fetus. See, position of the fetus means the fetal head position in relation to the maternal pelvis. Okay, so the fetal head position in relation to the maternal pelvis. The most common position is going to be left occipito-transverse. Okay, left occipito-transverse position is the most common position of the fetus during the labor. Now, after this, let's talk about a few important points. Most common estrogen during the pregnancies. The most common estrogen during pregnancy is estradiol, E2. Most specific estrogen during pregnancy is E3, estriol. And what is the source of estrogens, guys? The source of estrogens, we have discussed that. See, the placenta cannot make the estrogen by itself alone. So, the raw product, okay, the raw material for the production of estrogen is fetal, okay, dihydroepiandrosterone sulfate, okay, DHEAS. So dihydroepiandrosterone from the fetal adrenal glands will be used by the placenta for the production of estrogens. Okay, the main trigger for initiation of labor. The main trigger for initiation of labor, okay, for the kick-starting the labor is CRH, corticotropic releasing hormone from the fetus. Fetal CRH is the one which triggers the labor. Now, let's see, the placental separation and membranes are expelled in. So, in which stage of labor the separation of placenta is going to happen? The placental separation happens in first stage, second stage, third stage. The first stage of labor is all about the cervical effacement and cervical dilation. The second stage of labor is all about the delivering the baby. The third stage of labor is all about the separation and delivery of the placenta. Okay, so in the third stage of labor, the placenta will be separated. Now, the Bandal's ring is, guys, we have seen what exactly is Bandal's ring and that constriction ring. See, the Bandal's ring is a pathological retraction ring. Okay, the Bandal's ring is a pathological retraction ring which can be seen from the which can be seen directly which can be seen abdominally. Okay, so this pathological retraction ring can be felt abdominally, but we have discussed in the topic of labor that this constriction ring can be felt only vaginally. It cannot be felt abdominally. Okay, so why there is this this Bandal's ring? The Bandal's ring is mainly because of or mainly seen with obstructed labor. Okay, see, this Bandal's ring or this pathological retraction ring is seen in the obstructed labor. And the constriction ring, we have discussed that this constriction ring is because of injudicious use of oxytocin. If you are using oxytocin inadvertently, that causes uncoordinated uterine contractions. That causes this constriction ring. Constriction ring is physiological. Okay, so this constriction ring, it is physiological, but the Bandal's ring is a pathological and it's a retraction ring. Okay, that's a very important point. Now, mechanical stretching of cervix leading to increased uterine activity or increased uterine contractions. This is known as, see, when the baby is getting pushed against the cervix. Okay, the baby's head is getting compressed against the cervix. Now, this mechanical stretching of the cervix, it is leading to activation of the uterine contractions. This reflex name is known as, we have discussed, this reflex is known as Ferguson's reflex. Okay, so Ferguson's reflex or Ferguson's reflex is the cervical stretching. Okay, mechanical stretching of cervix initiates the uterine contractions. Okay, that is Ferguson's reflex. Now, internal rotation of fetal head occurs at the level of, guys, when the baby's head is passing through the pelvic cavity, in the pelvic cavity there is this one particular area known as the plane of least pelvic dimension. So in that plane of least pelvic dimension, the ischial spines are protruding into the cavity, where the interspinous diameters will become just 10 centimeters. So what happens at that particular plane, in order to pass through such a narrow area, the internal rotation of fetal head will happen. Okay, fetal head will occur. So internal rotation is happening at the level of plane of least pelvic dimension, or at the level of ischial spines, or at the level of a zero station. All these are true. Okay, all these are the true statements. So internal rotation happens at the level of ischial spine. After this, let's talk about the fetal position refers to. See, fetal position. So what exactly the term position means? Let's see one by one. Okay, let's see the options one by one. See, relation of different parts of fetus with one another. Okay, the relationship of fetal parts to one another. See, this option number A is actually a definition for attitude. Attitude of the fetus. What exactly is attitude of fetus, guys? Attitude of fetus means the relationship of the fetal body parts to one another. Okay, that's the attitude. We will say the fetus is in a flexed position. The fetal head is flexed. The fetal head is partially extended. The fetal head is completely extended. So in relation to one another, okay, in relation to one another, like if the fetal parts in relation to one another is known as the attitude. Now, relationship of option number B. Relationship of denominator of the fetus to different quadrants of the maternal pelvis. Fetal head, like usually the denominator is going to be occiput. So the denominator of the fetal head in relation to the different quadrants of the maternal pelvis. What exactly is that? This is a position. So position means fetal head, how it is oriented in the maternal pelvis. See, whether the occiput is towards the transverse plane, whether it's in the transverse plane, or whether it is anterior, or whether it is posterior. So fetal position refers to relationship between the fetal head or the fetal skull in relationship with the maternal pelvis. We'll say left occipital transverse, which means the occiput is towards the left side, and that too it is in the transverse plane. Okay, very good. Now, relationship of long axis of fetus to long axis of maternal spine. What is this definition, guys? See, option number C, the relationship of long axis of fetus to long axis of mother. That is something lie. It's a definition for lie. Whether the lie can be longitudinal lie or transverse lie or oblique lie also. Okay. Now, part of presentation which lies over the internal cervicals. See, that part of presentation which is lying over the internal cervicals and which can be felt first. Okay, which is going to be felt first by pervaginal examination. See, this definition is for presenting part. Okay, presenting part. Okay, now let's see all these definitions one more time. See, lie means relationship of long axis of the fetus to the long axis of the maternal spine. Now, presentation means part of the fetus, okay, occupying the lower pole of the pelvis. See, presentation means part of the fetus which is occupying the lower pole of the pelvis. See, the presentation can be cephalic presentation, or the presentation can be breech presentation, something like that. Okay, now presenting part. What is presenting part? The part of presentation. See, presenting part is a part of presentation which overlies the internal os and first felt on pervaginal examination. And what is attitude, guys? Attitude means the relationship of different parts of the fetus to one another. That's the attitude, like flexion, deflection or extension. Now position, this is our question. Position means relationship of the denominator of the fetus to different quadrants of the pelvis. This is position. Okay. We have already discussed that the most common position going of the fetus will be left occipital transverse. Now, all of the following events are included in the first stage of labor except all events. See, cervical effacement will be happening in the first stage. Definitely. Cervical dilation will be happening in the first stage. Yes. And crowning of the fetal head. Guys, fetal head crowning is going to happen during the delivery of the baby. So delivery of the baby happens in second stage of labor. So crowning of the fetal head is not going to happen in the first stage. And fetal head descent beginning. Okay. Descent of the fetal head. With cervical effacement and dilation, automatically fetal head starts to descend down. So fetal head descent also is going to be seen in the first stage of labor. So the option here, the answer here is the C. Okay. So crowning of the fetal head is not going to be seen in the first stage of labor. Now, when fetus is in attitude of flexion, when the fetus is in the attitude of complete flexion, then the most common presenting part is, if the fetus is completely flexed, then the vertex is going to be the presenting part, and that's something normal. Okay, so vertex will be the presenting part when the fetal head is completely flexed. Engagement of fetal head is with reference to. Engagement of fetal head is with reference to. See what actually I mean by when we are going to say that fetal head is engaged. So the engagement is in relation to biparietal diameter, bitemporal diameter, bimastoid diameter, or suboccipitobregmatic diameter, mentovertical diameter. When? See, the definition of engagement is when the biparietal diameter, okay, the biparietal diameter, that's 9.5 centimeters. When biparietal diameter enters into the pelvic brim, that's the moment we will say that engagement has happened. So engagement of fetal head is in reference to biparietal diameter. See, take this note. When biparietal diameter has passed the plane of the pelvic brim, the fetal head is said to be engaged. Okay. Now, descent of the fetus is facilitated by all except. See, descent of the fetus is facilitated by all except. See, extension and straightening of the fetal body. True. Pressure of the amniotic fluid. True. Uterine contractions will push the baby down. True. Well flexed head. Guys, wait. See, actually when we have studied about the topic of mechanism of labor, we have discussed that. See, actually engagement, descent, flexion, internal rotation. This is the order, right? Guys, please concentrate. Engagement is followed by descent is followed by flexion is followed by internal rotation. See, for the process of internal rotation, you need to have a flexion of the head of the fetus. Flexion should be happening. So what I'm trying to put into your mind is, see, flexion is mainly needed. Okay, flexion is mainly needed for internal rotation to happen. But if I'm talking about descent, see, descent is going to happen because of the straightening of the fetal body. True. Pressure of the amniotic fluid and the uterine contractions are going to cause the descent of the fetus. But well flexed head, okay, well flexed head is going to mainly help in the internal rotation. So answer is D. Okay. Now see, please take this point. The descent of the fetus is facilitated by uterine contractions. True. Contraction of the maternal abdominal muscles. Okay, see, the mother is going to contract the abdominal muscles and she will try to bear the baby down. Okay, bearing down. So contraction of the maternal abdominal muscles, extension and straightening of the fetal body, and pressure of the amniotic fluid, all these things are going to contribute the descent. But internal rotation is because of well flexion, complete flexion of the fetal head. Now try to answer this. A 28-year-old primigravida at a term presents to the clinic for a general checkup. On examination, fundal height is equal to period of gestation And the head of the fetus is non-engaged. That is non-engagement. And right now she is at a term. What is the most common cause of this finding? Guys, please understand, at a term the most common cause of a non-engagement is idiopathic. We don't know. See, in 40% of the cases it is just idiopathic. Following that, see, in almost 28% of the women, it's the deflexed head of the fetus. So deflexed head is not going to is not going to engage properly. So that causes non-engagement. So non-engagement is mainly because of the most common cause is going to be deflexed head. Okay, the most common cause is idiopathic. But in our options, there is no such thing as idiopathic. So the better option would be deflexed head. Okay, so the most common cause of non-engaged head or unengaged head is idiopathic, followed by deflection of the fetal head, cephalopelvic disproportion cord around the neck, and placenta previa. Okay, all of them can be account for the non-engagement. Okay, now cardinal movements during labor are, see, the cardinal movements, what is the order, guys? The order is going to be engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion. Okay, this is the order, and definitely here and then these kind of questions will be coming in your exams. So option number B. Okay, the second option is the better option. The second option is the right one. Now, in vertex delivery, okay, that is something normal. In vertex delivery, the baby's head is delivered by, see, while you are doing a normal vaginal delivery and everything is absolutely normal, okay, the lie is going to be longitudinal, the presentation is going to be cephalic, and the presenting part is going to be vertex in a normal vaginal delivery. How the fetal head is going to be delivered? The fetal head will be delivered by flexion or extension. Actually, while the baby is passing through the pelvis, the flexion is going to be happening. Okay, the baby's head is going to be more and more flexed. But by the time the baby is coming out, okay, by the time the head is getting delivered out, the baby's head will be delivered by extension. But in breech delivery, the after coming head is delivered by flexion. Important MCQ. Okay, now let's see, all are the cardinal movements that occur during labor except, see, descent is going to happen during the labor, true. Restitution will happen, internal rotation will happen. Asynclitism, guys, asynclitism, is it a cardinal movement? No, asynclitism is not a cardinal movement. See, we have discussed about the asynclitism in the topic of maternal pelvis. See, if a mother is going to have a platyploid type of pelvis, okay, a mother having platyploid type of pelvis where the transverse diameters are greater than anteroposterior diameters, there what happens? The engagement happens by marked asynclitism. The engagement happens by marked asynclitism. So what happens? Actually, the biparietal diameter should be the engaging diameter. Okay, the biparietal diameter should be the engaging transverse diameter. But because of the marked asynclitism, automatically engaging diameters will change. Now, from the biparietal diameter, the engaging diameter will shift to super subparietal diameter. We have discussed. So, asynclitism is not a cardinal movement. Okay. Now, which of the following is needed for internal rotation of the head? Guys, we have seen what do we need for engagement, what do we need for descent? We have already seen. Now what we are saying is, what are the prerequisites for the internal rotation of the head? See, straightening of the fetal body. Actually, straightening of the fetal body is needed for the descent. Pressure of the amniotic fluid is needed for the descent. Now, contraction of maternal abdominal muscles. See, this contraction of maternal abdominal muscles is needed for the descent. Now, tone of levator ani muscles. See, the tone of levator ani muscles is very much important for the internal rotation. Yes. See, in the previous MCQ, we have discussed that the internal rotation needs a well flexed head. True. In the same way, internal rotation also needs a good tone of the levator ani muscles. So please concentrate guys here. What are the prerequisites for the internal rotation of the fetal head? See, it's a well flexed head, we have discussed. Efficient uterine contractions, true. The shape of the mid pelvis and the tone of the levator ani muscles. See, for example, the well flexed head is going to helpful in the internal rotation, true. The uterine contractions, guys, this is one important. See, uterine contractions are needed for descent as well as the uterine contractions are needed for the internal rotation also. Okay, both. Now the shape of the mid pelvis, guys. In the mid pelvis, we know that there is this this region called in the pelvic cavity. There is this region known as the plane of least pelvic dimension, where the ischial spines are protruding into the cavity, which compromises the diameter of the pelvis, which decreases the diameter of the pelvis. So you need, in order to have a good internal rotation, the shape of the pelvic cavity or the shape of the mid pelvis especially is very much important. Why? Because if there are these deep ischial spines, deeply protrude ischial spines into the cavity, means that causes arrest, that causes a deep transverse arrest going to happen. Which of the following statements is the true regarding internal rotation of the head? See, occiput turns towards the transverse axis. Guys, this is the transverse axis. But actually what happens right now in this image, it's very clear that the fetal head, is lying in a left occiputo transverse position. That's something normal. But while the baby is passing, while the baby is undergoing internal rotation, what actually happens? Now please concentrate. The fetal head is going to move away. The fetal head is going to, see, please concentrate here. In this animation, it's very clear. The fetal head is moving away from the transverse axis. True. So occiput turns towards the transverse axis. This is a false statement. Rotation is not essential when the fetus is usually small. Yes, that's true. When the fetal head is small, then there is no need for the internal rotation. It can easily, that such a small head can easily pass through the pelvic cavity. So no need of internal rotation. Internal rotation is followed by expulsion. No, internal rotation is followed by extension. Not the expulsion. Rotation is earlier in primigravida than multigravida. No, rotation is going to be earlier. Rotation is going to happen earlier in multigravida, not the primigravida. Now, prolonged latent phase in a primigravida is defined as prolonged latent phase. Guys, latent phase is actually a part of first stage of labor. Now, in the first stage of labor, there is this latent phase and active phase. Now, when we are going to say that the latent phase is prolonged, so according to the definition, in a primigravida woman, if latent phase is taking more than 20 hours, then we are going to call the latent phase as a prolonged. Now, please concentrate on the definition. Very, very important. In a nullipara female who have not entered the active phase, which means now still she is in the latent phase for more than 20 hours. Now if she is in latent phase, then we are going to call that latent phase as a prolonged latent phase. But in a multipara woman, if she is in this latent for more than 14 hours, then we are going to call that as the prolonged latent phase. Now, what is the most common cause? The causes of the prolonged latent phase is excessive sedation or epidural analgesia, and the management is simple. Management is morphine administration, painkiller, morphine administration, rest, and oxytocin stimulation. This is the management. Now, protracted active phase of dilation. Now we are talking about abnormalities of the active phase. Latent phase completed. Now, see, protracted active phase of dilation in a multipara is, please concentrate in the table. Protracted active phase of a dilation. We are talking about the dilation. See, protraction of a dilation in a nullipara female. If the dilation, during the active phase is less than 1.2 centimeter per hour. If the cervix is dilating less than 1.2 centimeter per hour, then we are going to call that dilation as a protracted dilation in active phase. But if you are talking in a multipara, see, the cervical dilation rate, it should be at least 1.5 or more than 1.5. If the cervical dilation rate is less than 1.5 per hour, we are going to call it as protracted active phase of dilation in multipara. So now see guys, protracted active phase of dilation in a multipara is less than 1.5 centimeter per hour. Okay, that's the correct answer. Now see, protracted descent in labor, descent of the fetal head. See, protracted descent in labor in a nullipara is, let's talk here, protracted descent, this part of the table. Actually in a nullipara, the fetal head should be descending at least 1 centimeter per hour. And in a multipara female, the descent of the fetal head should be at least 2 centimeter per hour. Okay, at least 1 centimeter per hour in a nullipara woman. At least 2 centimeter per hour descent should be there in a multipara woman. So when we are going to call it as a protracted descent means whenever the descent rate is less than 1 centimeter, when the descent rate is less than 1 centimeter in nullipara and the descent rate is less than 2 centimeter per hour in multipara, we are going to call it as protracted descent of labor. So in nullipara, the answer is going to be less than 1 centimeter per hour. Now, okay, answer was already given. The assessment of progress of labor is best done by, it is a partograph. Okay, with partograph, you are going to have a best assessment of the labor. Now, let's see this question. During active labor, the minimum rate of cervical dilation in primigravida is, in a primigravida, okay, what should be the minimum rate of cervical dilation in active labor? We have already discussed, guys, please concentrate. In active phase, the cervical dilation rate should be, okay, see, in a primigravida or nullipara, the cervical dilation rate should be at least 1.2 centimeter per hour, and in a multipara or multigravida, the cervical dilation rate should be at least 1.5 centimeter per hour. So what's our question is asking? During active labor, the minimum rate of cervical dilation in primigravida is 1.5, sorry, in a primigravida is 1.2 centimeter per hour. Okay, now identify a WHO guideline in second stage of labor among the following. So what is the WHO guideline among the 4 options? Okay, episiotomy should be done in all the NVDs. No, there is no need for episiotomy to done in all the NVDs. Manual support to perineum to maintain the flexion of the head. Yes, so manual support should be given to the perineum. So with that, you have to maintain the flexion of the fetal head. Yes, this is a WHO guideline. Okay, this is a WHO guideline. This option is true. Okay, now identify the fetal head position in the given image. Guys, see, this is the right side, this is left side, here is the occiput, and like this is anterior, this is posterior. So you should tell me what exactly is the position of the fetal head. See, it is left. Okay, why? Because occiput is our denominator. Left occiputo, which means the occiput is towards the left side. Left occiputo, it's lying in the transverse plane. Okay, it's lying in the transverse plane. So left occiputo transverse, and left occiputo transverse position is going to be the most common position. Okay, most common position of the fetal head during normal labor. Now, uterine contractions are painful when its intensity is more than. See, when a female is going to feel the uterine contractions as painful with how much? Okay, with how much intrauterine pressure, the uterine contractions are going to be painful. It is more than 15 mm of Hg pressure. Okay, I should be actually writing here more than 15 mm of Hg pressure. See, the uterine contractions are going to be palpable when the intrauterine pressure is more than 10 mm of Hg. They are going to be painful when the intrauterine pressure is more than 15 mm of Hg, and with 15 mm of Hg pressure, the cervical dilation, going to happen. Okay, with 15 mm of intrauterine pressure, cervix starts to dilate. Now, Ridgen maneuver is done in for delivery of head in the normal labor, for occiputo posterior position, for delivery of after coming head in breech presentation, for delivery of legs in breech. We have discussed that Ridgen's maneuver is done for delivery of head in a normal labor. Okay, for delivery of the head in normal labor, Ridgen's maneuver. Pain in early labor is perceived through which spinal nerves? See, the pain in early labor, see, the labor starts with the uterine contractions, and these uterine contractions are definitely going to be painful. So whenever the uterus is contracting, the pain sensations from the uterus are taken to the central nervous system by which nerves? Okay, which spinal nerves? We have seen that T10 to L1 spinal nerves. T10 to L1 spinal nerves are going to take the pain sensation from the uterus to the CNS in the early labor. Okay, so pain sensations from the uterus are carried by T10 to L1. Okay, and from the cervix and the perineum, the pain sensations are going to be carried by S2, S3, S4 in the later stage of the labor. But in early stage of the labor, the pain is because of the uterine contractions, and the pain is going to be carried by the T10 to L1 spinal nerves. The nerve roots blocked in the pudendal nerve are. So this is a very simple MCQ. So you just need to know what is the root value of a pudendal nerve. We know that pudendal nerve is going to supply to the area of pudendum. Okay, the vulva. Now the pudendal nerve is going to be made up of S2, S3, S4. These are the root values. So the pudendal nerve block, you are going to, for pudendal nerve block, you are going to block the S2, S3, S4 nerve roots. Okay, so this is the S2, S3, S4. The roots blocked in pudendal nerve block are S2, S3 and S4. True. Now paracervical block relieves the pain from all of the following except. Paracervical block relieves pain from all except. Guys, see, if you are trying to do episiotomy or while you are doing instrumental deliveries, we are going to definitely give the pudendal nerve block. But there are some times where you need to give a paracervical block. See, these all blocks are just to ease the process of labor, to decrease the pain during the labor. So paracervical block, it relieves the pain from all of the structures except, see, paracervix. The block you are going into the paracervix. So automatically the pain from the cervix is going to be decreased. The cervical dilation, that doesn't actually cause pain. Okay, with the paracervical blocks. So no pain is getting perceived from the cervix, no pain is getting perceived from the uterine contractions, and no pain is going to be perceived from the upper parts of the vagina. Why? Because the cervix is lying in close proximity to the vagina. So no pain coming from the cervix, no pain coming from the uterus, and no pain is also going to be carried from the upper vagina, but not the lower vagina. Okay, lower vagina, it's getting its nerve supply from the pudendal nerve. So please answer this. Paracervical block relieves the pain from all of the following except, see, does it relieves the pain from dilatation of the cervix? True, it relieves the pain. Pain from the uterine contractions are also going to be decreased. Lower third of the vagina, no. Lower third of the vagina, like, this paracervical block is not going to relieve the pain. Upper third of the vagina, yes. Upper third of the vagina, the pain will be reduced. So the answer is C. Okay, except, we are talking about the except. See, in paracervical block, it is not useful at the time of episiotomy. Yes. See, why this is not useful at the time of episiotomy? Why? Because this paracervical block doesn't anesthetize the lower part of the vagina. So definitely for episiotomy, this paracervical block is not enough. You have to go with the pudendal block. Now, see, this paracervical block is considered as unsafe because it's going to cause a fetal bradycardia. Okay, paracervical block is associated with a fetal bradycardia. True. Now, a 36-year-old primary gravida at 37 weeks of gestation come with the complaints of decreased fetal movements for the past 2 days. Okay, the ultrasound, okay, on ultrasound, the fetal cardiac activity was absent, which means the fetal demise, fetus was dead. What is the next best step in the management? What is the next best step? Now she is carrying a dead fetus. She is carrying a dead fetus. Now what to do? Are you going to continue up to term? Definitely we are not going to do that. Okay, why you just ask this woman to carry the dead fetus? Okay, usually we won't do that. Okay, now wait for the spontaneous expulsion, the C-section, artificial rupture of membranes. What to do? Guys, already the baby is dead. Already the baby is dead. What is the need to rush? Okay, don't rush and do the C-section. Why? Because don't give scar unnecessarily. Don't give this female scar unnecessarily. So C-section is totally out of the option. Okay, we are not going to do the C-section at all. We are not going to continue the dead baby till term. And artificial rupture of membranes, guys, when the baby is dead and getting macerated inside the uterine cavity, if you do artificial rupture of membranes, there is a lot of chance of infections. Okay, there is a lot of chance of infections. So having a dead baby inside the uterus, we usually don't go for the artificial rupture of membranes. So what we will do is, we will wait for the spontaneous expulsion to happen. If spontaneous expulsion is not happening, we will induce the labor with oxytocin. Okay, if for spontaneous expulsion is not happening, we will induce the labor, but we are not going to do the artificial rupture of membranes. Midline episiotomy performed has extended away backwards beyond the perineal body. Actually, the midline episiotomy, usually we are not going to do that. Okay, mediolateral, we have discussed the mediolateral episiotomy is preferred than midline episiotomy. Why? Because midline episiotomies are going to extend. Whenever they are getting extended, they are affecting the external anal sphincter, internal anal sphincter. So anal sphincters will be affected when the episiotomy will be extended back. So here the option is, without any without even checking the other options, you can simply say that external anal sphincter, okay, external anal sphincter will be affected if episiotomy was extended. If episiotomy has extended, definitely anal sphincters will be affected. First external anal sphincter will be affected, followed by internal anal sphincter. Okay, now the most common cause of true cephalopelvic disproportion in India is cephalopelvic disproportion for this particular pregnancy. Okay, for this particular pregnancy, either the baby's head is small for the, either the baby's head is big for the pelvis, or the pelvis is small for the fetal head. So the most common cause of cephalopelvic disproportion in India is rickets. Okay, rachitic pelvis. Okay, rickets is the one which causes a cephalopelvic disproportion. The baby's head cannot pass through the maternal pelvis, or the baby's head cannot engage into the pelvic brim. Identify the instrument which is commonly used in the obstetrics. Guys, this instrument or these scissors which are more angulated, okay, which are more angulated. So these angulated scissors are repeatedly asked MCQ. These are episiotomy scissors. Okay, episiotomy scissors. There is no catch, and the angle is the blades are more angulated. So these are episiotomy scissors. Now, a 37-week primigravida has mild labor pains for 20 hours. Okay, now she is having mild labor pains for 20 hours. Now she is at term. Right now she is in labor. Cervix is 1 centimeter dilated but not effaced. What will be the appropriate management? Right now she is in first stage of labor, that too latent phase. Why? Because she that 5 centimeters is not yet dilated. Once 5 centimeters dilated, now she is in the active phase. After 5 centimeters, from 6 centimeters, now she will be in the active phase. But right now she is only 1 centimeter dilated. Her cervix is only 1 centimeter dilated. So definitely I can say that she is in latent phase. For how much time she is in latent phase? For almost 20 hours. Okay, she is in latent phase for almost 20 hours. So nullipara in latent phase for more than 20 hours should be considered as a prolonged latent phase. Prolonged latent phase. And what is the management of prolonged latent phase, guys? It's morphine and rest. Okay, morphine and rest. So sedation with morphine and wait. Okay, this is the option. Now, true labor pain includes all except. Now there is something called as a true labor pains versus false labor pains. See, true labor pains include all. See, true labor pains are painful or not? Yes, true labor pains are painful. This statement is true. They relief with enema will be seen. Guys, if it's a true labor pain, there won't be any relief with enema. If it's a false labor pain, there will be relief with enema. Why? Because that labor pain might be because of constipation. So true labor pains are not going to be subsided with enema. False labor pains will be subsided with enema. So that's a very, very important point. True labor pains, you will be having cervical dilation. With false labor pain, there is no cervical dilation. Show is going to be present. That mucus plug is going to simply dissolve and it's going to come out. Show will be seen with the true labor pain, but there is no show with the false labor pain. So the answer is relief with enema is not going to be seen. And here you can see in this table, you can see all the points. See, in true labor pains, cervical dilation is going to be present. With false labor pains, there is no cervical dilation. Pain is going to be seen and that's going to be radiating towards the thighs. Okay, because of the uterine contractions, pain will be there and that pain is going to radiate towards the thighs. But In false labor pain, the pains are going to situate only in the lower abdomen only, lower abdomen, no radiations. Okay, show is going to be present in true labor pains, but there is absence of show. And relief with enema, this is our question. See, true labor pains, there is no relief with enema, but with false labor pains, you will have a relief with enema. Okay, now all of the following are indications for early cord clamping. Guys, in active management of third stage of labor, okay, in active management of third stage of labor, there are three components. What are those three components? Giving oxytocin, okay, giving oxytocin, delayed cord clamping, okay, delayed cord clamping, and controlled traction of the cord, these are the three components of the active management of third stage of labor. Usually we will do delayed cord clamping. See, if you do delayed cord clamping, that is you have to clamp the cord not less than 3 minutes. Okay, usually you will clamp the cord between 1 to 3 minutes, to be frankly speaking. See, if you clamp the cord between 1 to 3 minutes, then that is known as a delayed cord clamping, which means you are not going to clamp before 1 minute. Before 1 minute, you are not clamping. Why? Because if you do so, all the blood which is present in the umbilical cord will be again taken back by the baby. So that prevents neonatal anemia. Okay, so delayed cord clamping is something which usually we do. But there are certain indications for the early cord clamping. What are they? See, RH isoimmunization. Yes, this is an indication for early cord clamping. Birth asphyxia. Okay, birth asphyxia, the fetal asphyxia, it's an indication. Maternal diabetes mellitus. Yes, this is an indication of early cord clamping, but not the post-dated pregnancy. Post-dated pregnancy is not an indication for early cord clamping. So the answer is B. Now, a pregnant woman comes with obstructed labor. Investigations reveal fetal demise. What will be the management? Guys, I have already discussed with you. If a baby is dead, go with a normal vaginal delivery. Don't give scar unnecessarily. But in this question, the fetus is dead. Okay, the fetus is dead. But wait, there is this obstructed labor. So dead fetus with obstructed labor. The labor is obstructed. The baby can't be delivered vaginally. So you have to go with a C-section only. So C, with the dead fetus, okay, dead fetus plus obstructed labor, or dead fetus plus placenta previa, dead fetus plus a transverse lie. Okay, in all these conditions, usually with a dead fetus, we do normal vaginal delivery only. But there are certain indications where you have to go with a C-section. What are they? Obstructed labor, placenta previa, transverse lie. In these conditions, you have to do the cesarean section. Okay. Now, signs of the placental separation in stage 3. Okay. So, signs of placental separation in stage 3 of parturition or labor include all except. See, what are the signs of placental separation, guys? Gushing of blood. Okay, gushing of blood. Yes, it's a sign of placental separation. A shortening of cord. When the placenta is separated, actually more cord will be coming out. That's a lengthening of cord. So lengthening of cord is a sign of placental separation, but not the shortening of cord. So this is the correct option. Shortening of cord is not a feature of a placental separation. Lengthening of cord is a feature of placental separation. See, when the placenta is separated, that placenta will be coming to the lower uterine segment. So suprapubic bulge will be seen, Schroeder sign will be seen, Kushner sign will be seen. We have discussed them. Okay, Schroeder sign, Kushner sign. Uterus will become ballotable, gushing of the blood. You will have a suprapubic bulge can be seen. All these are the signs of placental separation, but not the shortening of the cord. Okay. Now, you were asked to plot a partograph to monitor the process of the labor. Okay, you were asked to plot a partograph to monitor the process of labor. Okay, after how much dilation of cervix you are going to start plotting the graph? Okay, this is a very, very important MCQ. See, after how much dilation of a cervix you are going to start plotting the graph in the partograph. It is 4 centimeter dilation. With 4 centimeter dilation, from 4 centimeter dilation, you are going to start the graph plotting in the partograph. Okay. Now, all of the following are seen in scar dehiscence except. See, scar means like previous C-section scar. See this previous C-section scar right now, see, imagine that there is this female who is at a term, now she is having a previous C-section scar. Now such a scar is a very weak area with uterine distension, with uterine distensions. That area can easily rupture. So this is impending rupture. Uterus about to rupture. When a uterus is about to rupture, you will see certain features in the mother, okay, and certain features in the baby also. What are those features? See, scar dehiscence or impending rupture features are the fetal bradycardia. Okay, fetal bradycardia will be seen. Vaginal bleeding will be seen. Hypotension, hematuria, all these are seen, but not maternal bradycardia. Maternal bradycardia is not seen. Maternal tachycardia is seen. Okay, but fetal bradycardia is seen. So, what are the signs of impending rupture or scar dehiscence? They are fetal bradycardia, hypotension, pervaginal bleeding, hematuria, all of them can be seen, but not the maternal bradycardia. Maternal tachycardia will be seen. See, scar dehiscence, what kind of features you will see? Maternal tachycardia, fetal bradycardia, hypotension, pervaginal bleeding, hematuria, and scar tenderness. Okay, scar tenderness can be seen. True. Now, a primary gravida at 38 weeks was in the labor ward. Okay, right now she was in the labor ward. The uterine contractions are uncoordinated and frequency is about 8 contractions in 10 minutes. Guys, this is a keyword. 8 contractions in 10 minutes, and that too, those uterine contractions are uncoordinated and the frequency is more than 8. Now, which of the following is not true regarding your finding? Guys, first of all, what is this case? In this case is talking about tachysystole. So tachysystole means more than 5 uterine contractions in 10 minutes. So in 10 minutes span, if you are having more than 5 uterine contractions, then that's going to be called as a tachysystole. Uterus is contracting more number of times. If uterus is already contracting more number of times, are you going to give oxytocin again? You definitely are not going to do. If you do that, that's going to be a foolish treatment. So oxytocin should be administered. This is something false, right? So what they're asking, which of the following is not true? Not true. Oxytocin should be administered. This is not true. Okay, this is something wrong. Okay, that's the option. So usually there is a tachysystole, you can do a wait and watch, and this tachysystole is going to be very much common in the nulliparous females, and usually this tachysystole is associated with the occipito-posterior position. Okay, occipito-posterior position of the fetal head. Okay guys, so we have discussed all the important MCQs from the topic of labor. Hope the video is helpful. Thank you.